Welcome everyone to this online educational presentation on the subject of equine esophageal obstruction, otherwise known as equine choke. This presentation is geared for horse owners, so let's get started. The presentation is brought to you by veterinary technicians Michelle Vaden from Georgia and Colleen Davis from Texas. The presentation will cover the areas of equine digestive system, defining what choke is, what part of the digestive system gets disrupted to cause a choke event, and what are the clinical signs. My colleague Colleen Davis will cover the areas of diagnostics used for a choke event, treatments available, prognosis for the horse, and prevention that can be applied so that you will hopefully never encounter a choke event. What is choke? Choke is when there is an obstruction in the esophagus, usually by feed material when it gets stuck. In comparison to humans, choke in humans is caused by something lodged in the trachea, which then blocks the airway. In horses, choke is caused by something lodged in the esophagus, but a choking horse can breathe, but a choking horse cannot swallow. So the good news is that because this is not an airway or trachea obstruction, but can be, and we will discuss that in a bit, a choke is not usually considered life-threatening. However, it is a condition that must be corrected so that complications do not become a serious threat to the horse's health. So here in this slide, we have the equine digestive system. The horse's normal digestive tract is as follows. The food, grain, hay, treats, etc. enters the mouth, gets chewed up, which is now called digesta, and then will continue through the digestive system as a digestive bolus. That is a small rounded mass of chewed up food. The bolus gets pushed into the back of the pharynx. It now gets moistened with saliva. Then the horse swallows it and the bolus enters the esophagus. The esophagus of the horse is a 4-foot muscular structure that terminates with a sphincter, which seals off the bottom of the esophagus to the stomach. The digestive bolus will continue down this 4-foot tube on its way to the stomach, where further breakdown occurs in the stomach. Then it is continued to go along the small intestine. Absorption occurs in the small intestine, then continuing down to the large intestines to the colon. Then the waste is excreted through in the feces. The area where the horse is more likely to have a choke event is at the beginning of the esophagus, which is like right here. And the esophagus entrance to the chest cavity and the esophagus entrance to the stomach. All these areas have a narrow area that are often the sites of obstruction or choke events, and we'll see that in the next slide. So in this slide, you can see representation of the actual route for the digestive bulla to go. Enters the mouth, goes chewed up in here, becomes a digestive bolus, continues on, mixes with saliva over here, gets swallowed, and goes down into the 4-foot esophagus and down to the stomach. So here's another slide indicating the example of a digestive bolus traveling path. In this slide, you will see the first area in which a choke can occur in the digestive route indicated by the green color. From the mouth, passes by the soft palate, and the digestive is passed down the food tube, down the esophagus. You can see in this image that there are 2 valves blocking the digestive from entering the soft palate and the nose. Here's the 2 valves right here. We don't want that to go through there. So, a valve blocking off the windpipe or trachea and does not allow any digestives to enter the pulmonary system. If the digestive enter the pulmonary system, that could be a detrimental and life-threatening event, which will now become aspiration pneumonia, which is a complication caused by pulmonary aspiration, and that is when you inhale food into the lungs, thus causing an infection or obstruction, causing a pulmonary obstruction, which is a life-threatening situation, and that's another subject. So here is another slide indicating the digestive bolus getting stuck right in the beginning of the esophagus. So here's the pharynx, the digestive bolus will go through the mouth, get chewed up, will enter right here, mixed with saliva, pass through the pharynx, and here is the beginning of the esophagus, and that's where it will get stuck. That's a very common area where it gets stuck. And in this slide, you can see representation of the whole esophagus. Well, it's actually a tube that's entering the horse and going into the stomach, but you can actually see the route and how long it would be. Okay. So what are the clinical signs associated with equine choke events? Are coughing, yawning, arching neck, drooling, and difficulty breathing. So here is an example of a video of a horse having a choke episode that I pulled off of YouTube. And the horse's name is Sparky. And on May 3rd, 2012, Sparky apparently ate his grain too quickly and it jammed in his throat. It cleared on its own while they were waiting for the vet to arrive. He was totally fine, nothing happened, but I wanted you to see this video. It's a good video presentation. So you can see in the video, let me start the video. And you can see in the video the repeated times that Sparky swallows. He's going to stretch out his neck a few times, does the flame-in response right there. And that's when an animal inhales with the mouth open and the upper lip is curled up. And you can also see that Sparky is getting agitated in his body movements. And see him swallowing. Let me play that one more time. So he's stretching his neck out, and he's going to have repeated swallowing events right there. Shaking his head, something's getting stuck, stretching out, and it's getting stuck right over here. You can see him swallowing, repeated swallowing events, agitated, and eventually he will become comfortable. So, and for Sparky, it was a good thing. He naturally passed it on his own. So this is the end of my presentation. I'd like to introduce my colleague, Colleen Davis. She is a licensed veterinary technician from Texas, and she will now continue the presentation.
Hello, my name is Colleen Davis, and I will be continuing this seminar on esophageal obstruction in horses. So the first topic that I will be speaking about is the diagnostics. The clinical signs of esophageal obstruction are usually diagnostic on their own. However, an endoscopic examination can help to localize the site of the esophageal obstruction, the type of obstructing material that you're dealing with, and the extent of esophageal ulceration that has already occurred. Because of the risk of aspiration pneumonia, the respiratory tract should also be evaluated. So that includes auscultating the lungs and the heart, and then doing thoracic radiographs to see is there any chance of that happening as well. In complicated or chronic cases, a CBC and serum chemistry should also be run just to check for any other problems. In horses, for treatment of esophageal obstruction, it can spontaneously resolve on its own if food and water are withheld for a while. This can also be aided in administering IV sedation. So sedatives such as xylazine can help the horse to relax and therefore pass the obstruction on their own. Oxytocin and buscapine have also proven useful to help relax those esophageal smooth muscles. To ensure that the esophageal obstruction has resolved completely, all horses with a suspected obstruction should have a nasogastric tube passed into the stomach or have an endoscopic exam done to make sure everything has been cleared. Horses that do not respond to conservative management, such as taking away food and water, giving IV sedatives, or oxytocin, should be initially treated with an esophageal lavage. So that includes giving IV sedation, passing a nasogastric tube to the level of obstruction, and then delivering water to the obstruction site with a stomach pump, and then the tube is slowly inserted and withdrawn to lavage the esophagus. The head must remain lower than the torso to minimize the aspiration of water into the lungs, and you should lavage via the nasogastric tube. Typically, this can help you get success in getting rid of the obstruction about 90% of the time. However, if the horse is still unresponsive to this standing esophageal lavage, they can be placed under general anesthesia and make sure, again, to position their head lower than torso, and then pass a endotracheal tube, and then feed the nasogastric tube through the endotracheal tube, either as far as it'll go or to the level of esophageal obstruction, and then follow the steps of lavaging from there. Again, you should always make sure to check and make sure the whole esophageal obstruction has been passed with either a nasogastric tube or endoscopic exam. You can perform an esophagotomy, but it's rare. It is an option, but very rarely is it needed. Prognosis is typically very good if it's just a primary feed impaction and it's cleared within 24 hours or less. Inhalation pneumonia can definitely complicate this process, so if there are secondary complications, it can really make the prognosis not as great. Strictures can also form secondarily from severe mucosal damage, so you may have to deal with those. And then when this is secondary to a predisposing cause, the prognosis is going to depend on how bad the individual inciting lesion was. So for prevention of choke, if a horse is not chewing their food properly, a lot of the time they're going to be more likely to choke. So you should always try to correct improper chewing. Try to do a good dental exam at least once a year. And if there are any teeth that are causing a problem, correct those dental problems so that the horse chews better and therefore can swallow their feed better. If a horse is eating their grain too quickly out of their bucket, a shallow feeder may be needed, so that way they have to physically take more time to eat, and that can, again, help cut down on the chances of them having an obstruction. Some horses will also eat too quickly when there are other horses present because they are afraid that the other horse will take their food from them. So a lot of horses need to be isolated while they are eating. That way they don't feel like they need to chow down on their food super fast to prevent another horse from getting it. Again, feeding hay is always an option before grain. That way they partially feed up on or fill up on the hay before eating their grain. Then they might not eat their grain so aggressively. If a client were to suspect choke, we would recommend that the first thing they do is just remove any food or water that is present near the horse. We don't want them to eat or drink anything and just continue to cause more obstruction. They should observe the horse for the next 10 to 15 minutes, watch for symptoms. If the symptoms seem to resolve and the horse seems to go back to normal, they can offer a little bit of water but no food for about 1 to 2 hours and just continue to observe the horse. However, if these signs and symptoms of obstruction do not clear within about 10 to 15 minutes, they should contact the veterinarian to get the horse treated. So we hope you have enjoyed watching our seminar on esophageal obstruction in horses. If you have any questions, you can email me at colleendavis1992@gmail.com, or you can email my colleague, Michelle Vaden, at hotmail.com. Thank you.